We go on to the last topic, which is Dr. Shruti. She would be talking on quality and safety aspects in histopathology laboratory. Dr. Shruti has a very rich experience of more than 20 years in the area of lab medicine. She has been she is an NEPL technical assessor and has to her credit various international and national publications. She's a member of the esteemed IAPM as well as IMA. Welcome, Dr. Shruti, and request you to go ahead with your presentation.
Yeah, thank you, ma'am. I'll just share my slides. So good evening, everyone. Am I audible?
Yes, Dr. Shruti.
Yeah. So firstly, my gratitude and thanks to Kaho for making me a part of this education and a learning series. And thank you, Dr. Simi, ma'am, that you've given me a good introduction. And I would, before I start, I would thank Dr. Anne and Dr. Vanita, madam, too. They have nicely summarized and illustrated quality assurance in all the three phases. And I really hope before I start my presentation, I have something to offer and to keep the audience engaged. So my focus will be quality assurance and the safety aspects in histopathology laboratory. So I will start with a quote: "To err is human, which is a fact of life." So we all human beings, we make errors, and in our normal life also errors are there. So errors do occur in our laboratory activities, but however, these errors will translate to adverse patient outcomes and they may incur financial and time loss. So how to control these errors? And in histopathology tests, we need to control these errors. Why so? As surgical pathology is final, definitive, and a gold standard in the diagnosis of many diseases. However, this field of surgical pathology is highly subjective, interpretative, and opinion based. So that is why it is associated with little homogeneity in the reporting across the world. So standardization is the call of the day and very important in surgical pathology. The generation of accurate and reliable report is crucial in patient care. So we have the tools like quality control and quality assurance programs. So quality control is defined as a system for verifying and maintaining level of quality in a process or individual test, and is to be done from specimen collection in histopath till the time the physician or the patient receives the report. So this all has been emphasized earlier by Dr. Vinita and Dr. Anne. So I'll go fast in these slides. It's quality control and quality assurance. Quality control is the tools. So I will highlight the tools, how we are going to implement actually the quality assurance in our histopath section. And quality assurance is the overall management, which is a system. So the basic tool for quality control is the internal quality control and the external quality control, or the proficiency testing, or the EQUAS. And IQC, it measures repeatability, reproducibility, the precision, and covers all the three phases. And likewise, the EQUAS and the proficiency testing, which we are going to enroll ourselves in, has to cover all the three phases of surgical pathology and will tell us how close we are to the true diagnosis and how accurate we are. So this is the cycle which has been shown in the previous slides of my esteemed speakers, the quality assurance cycle from the collection to the post-analytical reporting. I will not go into the detail. So pre-examination is, the importance of sample collection and transportation, if reiterated again and again, is still less, because this is where the whole of the process is going to start. How the tissue is going to be collected and transported to the laboratory? What are your standard operation guidelines for that? Have you mentioned it in your sample manual? If you are going to get the sample from the remote site, are they aware of the recommended fixative, which is the 10% buffered formalin? Are they aware if it is coming from the OT or anywhere outside? Are they aware of the recommended cold ischemic time, which ideally has to be less than 1 hour? And in case, what are the impacts if the fixative is not 10% buffered formalin? It is not ideal. What impact it is going to have? And the fixation recommended minimum is 6 hours per small biopsy and 24 to 72 hours fixation for resected larger specimen. We have the monitoring of pH of formalin with a pH meter has to be very regular, and a log and a record has to be maintained for that. And the ideal pH is 6.8 to 7.4. Over fixation and under fixation both can give you trouble, or as the tissue usually has to go for IHC and molecular markers these days. And date of preparation of formalin has to be there wherever the technicians are making the formalin and storing it. Sample received and acceptance is another very important point. Wherever the samples and the specimen are being received in the laboratory, they have to really see the identification. They have to see the accompanying TRF and the gross forms, their adequacy of the gross forms, and have they included the clinical history. Those details have to be there. And acceptance and rejection, however, is not there. If there is a compromised sample, any issue is there with identification or the fixation, it has to be checked at the reception area and it has to be sorted out. So the analytical phase. In the analytical phase, in the examination process, we have, nicely detailed and highlighted by Dr. Anne. She's gone into much of the details. So we have the fixation, grossing, tissue processing, embedding, microtomy, light warming, tissue flotation, and staining. And of course, in the examination part, frozen section is a very, very, important part of reporting. Whenever it is recommended to have a separate demarcated area for frozen section. All the safety precautions have to be taken. The TAT has to be recorded for frozen sectioning, and concordance with final result also has to be maintained. Decontamination record of the frozen section, cryostat has to be there. So this, like an image I'm showing you, this is the grossing area. We have to see that we have a qualified, competent person, a pathologist, along with a trained technician. Appropriate grossing station with instruments has to be there. Exhaust and fume hood is very important. Along with that, formalin vapor monitoring is, it cannot be ignored, and all of the grossing stations need to have a formalin vapor monitor. We will go into the detail of formalin in my later slides. We have to record the findings, photomicrograph if the provision is there, and we can always have a resampling index and we can make a record of that. So we have a tissue processor. We have to verify processing program for small, large decalcified boards and fatty tissue, larger tissues, and in-house log recording time setting schedule for automated tissue processor. The temperature of the wax bath has to be checked and recorded, and it should not be exceeding 65 degrees Celsius. So microtome is one of the instruments. Proper working of the microtome, everyone needs to be trained on that. It is an area where safety is a concern, and it can be injurious to the lab technician if he is not accustomed or trained enough to be working on a rotary microtome. We need to have the calibration records. If we are using non-disposable knives, safety shields and disposable blades need to be there. Blade lock, blade guards, and wheel locks need to be there in the microtome. We need to see if there is a frequent change of blades, adequate cleaning before and after the process we are doing, we need to do that. Ensure that microtome is of good quality and is serviced regularly with a periodic calibration record of the micrometer, and so that the recommended consistency of the section thickness is maintained. Then we have the tissue embedding station and slide warming table. It is recommended that we should not be using any autofluorescence dyes because they may interfere with molecular and immunofluorescent testing in the future. Temperature of the slide warming table has to be checked daily and to be kept below melting point of wax. If for the tissue flotation bath, water has to be changed at least daily and skimmed regularly so that we do not get any floaters. Temperature monitoring intermittently to ensure it is below the melting point of wax. So having a paraffin wax of very good quality is the call, and it should be there. Paraffin is used for impregnation and embedding, and paraffin wax of low melting point below 60 degrees Celsius is recommended. We have to record the temperature of the paraffin bath, water flotation bath, slide warming table and it has to be done on a daily basis. Equipment need to be of standard quality and calibrated at periodic intervals. Care has to be taken as not to induce any tissue artifacts due to improper processing, sectioning, staining, and mounting. So all these, whatever I've highlighted, a laboratory needs to have maintenance log. And your maintenance log can be daily, they can be weekly and monthly in type, depending of the type of process or the work which is being done. So I'm just giving you an example, like for all equipments, you have cytospin, embedding station, incubators, microwaves, and so on. You can have a daily maintenance log. There are going to be things which have to be done daily, few things weekly, monthly, and further on. And you can also, for your technicians, you can really see that, what are the work-wise, how you can distribute it according to their expertise and their skill. Temperature and humidity daily log has to be maintained in the laboratory area. Reagent changing log for PAP stain or any other stains in the auto stainer has to be maintained. Daily QC for PAP, MGG, hematoxylin eosin stain has to be there. Log for formalin monitoring has to be there. Aqueous IQC failure, RCA, CAPA record has to be there. And harmonization and method verification, wherever two methodologies are being used, the harmonization and the comparability has to be there. So interpathologist record to be maintained. So further all, I'm just highlighting that we have the lot verification record whenever lots are being changed of stains, or verification of the IHC assays and antibodies. We do have a critical alert record. We have to define our criticals in a SOP for surgical pathology. Each lab has to do it. Training record has to be there. MSDS sheets have to be there. And calibration and PM of all equipments. Formalin, xylene, and other liquid. I will be coming to this point later on. The chemical discard log. How are we disposing and discarding our chemicals in the environment from the histopathology laboratory is very important. Block labeling and slide labeling errors. Frequency and cause of IHC repeats and IHC TAT. All this also needs to be monitored. We can additionally add recut, deeper cut, and re-embedding index too. So this is about the block labeling and slide labeling errors and frequency of cause of IHC repeats and IHC TAT, which I've already highlighted. So internal quality controls. Controls for routine, special stain, and IHC as a part of internal controls are run daily with each batch. The control slides have to be stained before the routine batch of slides, and the staining character regarding any artifacts, the nuclear quality, cytoplasmic, has to be compared with that of the previous day. By putting aside one block for control, One avoids variation related to any tissue type. A record of the staining characters have to be maintained. So this is in the staining, we can really see whether we have an automated stainer, we are doing it manually, and are we comparable and harmonized between both the methods? How are we monitoring the staining and the quality of the stain and the controls used, and we will record the controls which are being put up with each bat daily, and the artifacts, and maintain a logbook for the same. So this is just a histopathology quality testing schedule. It's just an example how you can just, summarize and keep it in your lab and just put it on the screen. What are the parameters and daily, what all you're doing? What are you doing with your spatial stain? Positive control you're putting. With your IHC, you're putting a positive control. What is the frequency and what is your acceptable criteria for the thing? Histopathology correlation, IHC antibody verification, what is the minimum criteria? So it is a tabulated form, and I suggest one can have a very concise thing and just put it in the laboratory and for demonstration so that the technicians can refer to it very promptly. So this is a little about verification of IHC antibodies and assays. So because earlier in the ISO 15189 and the NABL 112, it has been lately defined, and they have highlighted, because now a lot of laboratories, the histopathology centers, they are using IHC antibodies. So we need to verify and validate our IHC assays, and we need to have, each laboratory needs to have an acceptable study design. So we compare the new assay result with the expected architectural and subcellular location. We compare the result with the result of prior testing of the same tissue with a validated and verified assay in the same laboratory. And likewise, we can compare the assay with the result of testing of the same tissue in another laboratory, which is validated and verified assay, or like an ILC, and comparing the new assay result with the result of a non-immuno with another immunohistochemical method other than, like we can compare a fish result and an IHC result, even that can be done. And different fixators, we need to be very clear, different fixators may impact the sensitivity of the assay. And when all we are doing verification, validation, whenever we are getting a new clone, or our manufacturer has changed the clone, or we are changing our antigen retrieval method, at all those times we have to do the verification. So there are some examples where, neutral buffered formalin is not the fixative, so we have to do verification for them, and they are not in formalin fixed paraffin embedded tissues, like for direct smears or for cytospin preparations, liquid based cytology preparations, or cell blocks. So many labs are these days doing cell block, which are further going for IHC evaluation. And specimen collected in transport media such as saline or alcohol-based fixators, and that are subsequently processed in formalin to create a formalin fixed paraffin embedded cell block. So we need to verify them. So verification process for non-predictive markers, what is recommended? Recommended minimum of 10 cases, both positive and negative. So we need to correlate the result using new antibody with the morphology and expected result using appropriate controls. We have to verify the assay for repeatability on the same tissue by the same person. Then we have to verify for reproducibility on the same tissue by a second person. And lastly, we have to do an interlab comparison of our result with the NABL accredited laboratory. So this is the recommended verification procedure for your non-predictive IHC markers which need to be done. And likewise, we have the verification process for predictive markers where the recommended number is 20, and which should include your positive and the negative cases. And concordance for both of these non-predictive and predictive markers has to be more than 90%. Now, I have previously also highlighted wherever we are doing any automated IHC or staining manually as well as automated, or we are having two analyzers, we have two tissue processors, there has to be harmonization and comparability of result has to be there, and we can form a frequency, and we can make each laboratory can have their own design and protocol for that. But we have to address the comparability of examination. So analytical phase, we have covered the examination part. This is the report related part, which has been highlighted by my previous speakers also. The frozen section and permanent section concordance, this has to be reviewed. Peer review error rate has to be there. Histopathology turnaround time is very important. And we, in all reports, the integration of morphology with IHC result has to be. So this is one of my slides to show different methodology for peer review. I think I will not go into detail. Everyone has understood well, and it has been previously highlighted. So quality control in reporting, how do we capture it? TAT, we have to have standardized CAP, for example, CAP protocols for reporting, intra-departmental reviews for amended reports, corrected addendum reports, how many are there? We can do a calculation and we can just review that. What is our, how are we enrolled and how are we performing in our EQUAS, our proficiency test, and how many review requests do we get? So this is the post-analytical phase. Very shortly, transcription errors, verification errors, report delivery errors, incomplete reports, and diagnostic findings correlating with other ancillary studies. And where do we stand? We can capture our quality through all of these. Now, to increase the quality in a histopath, these are the some of the few points which are miscellaneous, which I can just say. The kind of, like today we are conducting a CME, conducting seminars. It is, continuous education and continuous improvement for any of the laboratory sections. We have to, besides for capturing non-compliances, we have to capture the near miss events and the potential non-conformities. And we have to do a RCA and CAPA for these. Staff should be briefed with each non-conformity, potential non-conformity. Also, the EQUAS result should be disseminated to all of the technical staff. Usually what happens is that it is within the pathologists and the doctors are discussing among ourselves, but where the EQUAS result should be really disseminated and briefed to the whole of the technical staff in the histopathology lab. So we review our documents. We need to have an audit plan, which I've not, previously highlighted. We need to have a staff detail manual, and a waste disposal record is also very important. So coming to my next part, we've spoken, my previous speakers have also highlighted quality assurance. Now, one of the very important aspects of a histopathology lab is health and safety in the laboratory. Safety for the technical staff. So safety rules in histopathology laboratory. Safety has to be responsible for each technical person who's working there. So in general, if we talk about, we should not, open-toed shoes should not be allowed in the laboratory. Certain kind of grooming like long hair, loose clothing to be avoided. Avoid to wear contact lenses, proper spectacles should be there. Washing hands and eating, smoking, drinking in the laboratory has to be restricted. And to wear your white lab coat, which has to be kept there, it should be changed 2 to 3 times in a week. So these are the kind of some general instructions which each of the technical staff should take care of, including the pathologists and the doctors. So safety hazards in a histopath lab or any other lab can be, it can come under 3 parts. It can be physical, it can be biological and chemical. Physical harm can be, you can think of anything from using a centrifuge to using a microtome, using your grossing equipment. So there can be a physical harm. Biological through your infectious agents. And I will be talking more about the chemical hazards in a histopathology lab, as well as how to have a safe use and how do we dispose them. So we need, in this regard, we need to have our PPE. We need to know about a chemical handling, biological hazard, and specimen handling. So biological hazard comes with your specimen handling. How well are we handling our frozen sections and sections of rose cytology specimens which are coming to our, which are highly infections? How are we handling our body fluids? So all those things have to be taken care of. Sharp object safety and equipment handling. Electrical safety is another very important. Clean work area and where are our emergency equipment. So this is our, PPE. It is what is the minimum recommended PPE? We must have a chemical resistant gloves, splash proof goggles, lab coat, face shield, rubber apron whenever necessary. We can, we can have more about knowledge about the gloves selection. We are using the non-sterile, sterile one, which are the ones which are recommended for any of the specific chemical we are working with. So these are the training requirements, in these three areas. We need to have specific work practices. We need to have a chemical hygiene plan or chemical plan, safety plan, which is incorporated in a laboratory manual. And the MSDs, where are they placed? Where is the location for that? And is our staff, well used to using it? And specific lab safety work. We can have a lab safety officer in each of the laboratory, which has who is responsible for disseminating and teaching the technical staff about the laboratory safety practices. So, and we have the lab equipment, the location and operation of the shower station, the eye wash, and what is the use of the fume hoods, storage cabinets, refrigerators, and other controls, and the waste handling and the spill response. So this all fuss about the chemicals, why these hazardous chemicals, and why do we need to be safe with them? Because they may cause you acute and chronic health effects. For all of the technical staff who's working in the histopathology lab, it can, acute effect can be which gives you symptoms within hours or days of exposure, and chronic, which may be, years on. So we must have a chemical hygiene officer and exposure of the control measures. How are we measuring it? How much are we exposed to the, hazardous vapors? And is our staff really, accustomed and trained? Have we educated about them, that what are the chemical, what are the hazards they are going to face? And do we provide them any kind of special medical consultancy, examination? Is it a part of their HR policy? So we as, histopathologists need to incorporate for the safety of our technical staff. We are responsible for them. So for any of their, their exposures, we have to minimize that. And if they get exposed, they need to get treated for that. So this seems a very busy slide, but we need to know the safety would be if we know the appropriate and recommended disposal also of the things. I will go very briefly in this. For my first one, which I'm highlighting, is your anatomic bio-waste, which goes in the yellow colored containers or the non-chlorinated bag that everyone knows about. Then this tissue trimmings from specimen, this has been added, and old paraffin blocks, this have to go in your red bags. The third point, which is very important and which, which has been added in our NABL 112, is regarding disposal of formalin and also disposal of xylene. So disposal of formalin, which we get from the discarded containers, once we are discarding the tissues and we are getting a good amount of formalin, are we just putting it down the drain or we are just putting it in the ETP? Are we neutralizing the formalin before we are putting it? How we are doing it? And what is the recommended? There are 2-3 ways we can really discard the formalin which we are doing. While doing the grossing, it may go into the ETP with copious amount of water. But otherwise, once a huge amount of formalin, when we are discarding our tissues monthly, ideally, we need to collect it and we need to give it back to our housekeeping and to the authorities and the agency. They should have a MOU where they further send the formalin for further disposal. And this is true for xylene also. I'm highlighting this point. Formalin and xylene, they need not be put through the ETP. Xylene is also highly, inflammable and it can cause explosion. Xylene should never be put in the sewer or the ETP. It needs to be collected and sent it back. And likely, isopropyl alcohol and DAP solutions used from IHC, they also need to be handed over in sealed labeled containers to the authorized agencies with documented MOU for the same for further disposal. So these are the changes which needs to be incorporated for disposal of formalin, xylene, your DAP solutions, your alcohol, and in the surgical pathology, as well as be very conscious of the effluent which is being which comes out of all the analyzers, how you're discarding the effluent. You need to have a policy for that also. So a little about formalin vapor level monitoring installed in the grossing room. What generally is happening is that people have kept the formalin monitor. Half of the time the formalin monitor is in non-functioning state, and the people are doing a monitoring during the grossing. But you need to cover other activities, like when you are grossing or the technician is changing formalin or he's putting from the stock solution to the other place, or during monthly discarding of the sample time, what is the formalin vapor levels which you are and the technician is being exposed to. We need to cover all this. Otherwise, it will just be a paperwork where we document that during grossing, this was there and we just fill in the log. So these are the recommended permissible limits and the guidelines. These are available for over 8 hours. We have formalin is 1 parts per million, and for short-term exposure, it should not exceed 15 minutes, and that is 2 parts per million. So formalin spill and safety protocol. I will recommend that all of the histopathology lab should have a SOP regarding formalin spill safety protocol and formalin usage in the laboratory. So formaldehyde exposure is a safety concern in anatomical pathology as it is considered to be carcinogenic. And we need to have a certain set of monitoring and working practices so that to prevent adverse health effects. So formalin spill, sometime or the other, each of the laboratory would have incurred or experienced a formalin spill. So first, whenever a spill is there, everyone is very much used to, blood spill or body fluid spill. Everyone is aware. Everyone has got clear guidelines for that. But what about formalin spill? If a formalin spill is there, how do we need to teach anyone, or do we need to really understand that? So it has been divided into minor and major spill. So in a minor spill, because histopath lab has got formalin in two concentrations, we may have above 35% or 10% formalin spill. So I will just give an example how to a minor spill can be a single leaking specimen containing 10% formalin, or a broken specimen that contains up to 100 ml of 10% formalin, or a partial full container greater than 100 ml 35% formaldehyde, but it is in a chemical, there is a fume hood is there, or a splash of concentrated formalin onto a surface. So these are examples of considering these as a minor spill. But in simplified way, in a major spill, if it is a multiple broken specimen of 10% formalin, maybe like for an example, whole of a collapse of a shelf is there, it is considered as a major spill. Or there is a partial or full container containing more than 100 ml of your 35% or more concentration of formic acid, as considered major spill. Or a stock bottle 500 ml or greater of 10% formalin onto a bench or floor. Or a single lab staff member who becomes injured and drops 1 to 2 specimen containers simultaneously. So these are broadly, some of the examples of minor and major spill. What you need to keep in your mind is how many containers, is there a fume hood where the spill has occurred, and what is the concentration of the formalin of which the spill has occurred. So what do we do? Minor formalin spill or less than 100 ml. Alert others in the area of the spill. Wear your PPE, and for the spilled material, you cover it with paper towels or absorbent spill powder. We are having formalin neutralizers also. The labs are keeping that. Place any paper towels and you cover wipe it and put it in contaminated, waste bag and seal to minimize the release of formaldehyde vapors. Do not dispose it into the general waste bin. Using a formalin spill absorbent is highly recommended, and many of the labs are keeping it as it absorbs the spill and neutralizes the odor. The formalin absorbent should be allowed to react for 5 minutes before it is collected and bagged. And the other of the area needs to be washed with soap and water. So this is a moderate formalin spill. It is 100 ml to 1000 ml. You need to do the same things. Only the difference from a minor spill is that you need to evacuate the immediate area so that unnecessarily person have a limited exposure to the irritating fumes. And in case it's a major formalin spill, you call your hazmat team and do not put yourself and others at risk dealing with a major spill without any assistance. Do not try to handle the major formalin spill yourself. So I'm just sharing you a picture of this formalin neutralizer. It is a chemisorb. You can keep it in your laboratory and it can be really beneficial for neutralizing your formalin, for discarding it, or you need to for managing a formalin spill. And this is just a pictorial representation of a chemical spill kill. So in general, how can we prevent chemical spills in a workplace? We should ensure that chemical containers are used with seals that are in good condition. They have to be stored appropriately, and the storage of chemicals has to be respective to their MSDS or the material safety data sheets. We have to ensure appropriate equipment and procedures are in place for chemical spill management. A chemical spill management kit has to be there. And the emergency actions I've already highlighted. Immediately alert area occupants, immediate senior, evacuate the area if necessary. Contaminated clothing has to be removed immediately. Skin flushed with water for not less than 15 minutes, and clothing must be laundered before reuse. If volatile, flammable material is spilled, immediately warn everyone. Control source or ignition, your electrical safety, and ventilate the area. Now, chemical spill in the eye, what you need to do, best practices are recommended. Contact lenses should not be worn in the lab. Rush to the nearest eye station. Flush your eyes with water for at least 20 minutes. Hold eye open during flushing. Ask for assistance. and contact MSDS department and provide the MSDS sheet to the attending physician. Very shortly, the don'ts of chemical storage. Avoid storing any chemical above your eye level. Don't store incompatible chemicals together. Don't store chemicals near source of heat or sunlight. Don't store chemicals in the hoods or acids or on metallic shelves. Avoid storing anything on the floor, especially glass bottles. These are some things, which are mandatory in the laboratory area. Safety showers, eye washes, they have to be available in the lab area, and combination of eye wash and wrench whose units at the sink are available, that can be installed in the laboratory. A plan of egress or exit plan has to be there, and each of the labs should have 2 or more well-marked unobstructed evacuation exits are recommended in laboratory premises. So this I'm just, I'm near to my conclusive slides. So these are the lab safety and laboratory safety, which I've already highlighted, how you have to deal with the chemicals, exposures, your fire extinguishers, your eye washes. I've already highlighted all of these points, which are very mandatory and should be implemented in any of the laboratories, especially histopathology. So take home message from my, today's talk should be quality control is an integral part of a medical laboratory. It helps maintaining, assuring and improving qualities of tests and reporting done in that laboratory. All this, whatever I've spoken and told everyone, should help in better patient care, safety of laboratory personnel, safe disposal of hazardous material, and optimal functioning of healthcare system. So this is my conclusive slide, which I will say that behind every great doctor is an exhausted lab technologist or a pathologist or, surgical pathologist technician. You can take it in any way. Thank you so much for a patient hearing. Thanks, everyone.
Thank you, Dr. Shruti. I think it was a wonderful presentation on safety. And we all realize how important it is, especially in the area of histopathology, because it's over here, you're dealing with chemicals, you're dealing with inflammables, you're dealing with, manual processes. And over here, in case we do not, take sufficient care, it could be a lot of problem. And
Right.
what I always say, like you said, that there is an exhausted lab technician. I always tell my lab people, you're working in the kitchen. And
Right.
whatever best processes you take, for me, ultimately the dish is a good slide. And that's
Right.
where we can report well. And that's where what Vinita said, turnaround time. Because if your slide is good, you don't need recuts, you don't need more sections.
Yes.
And if they are representative, I think half the job is done when the kitchen has fabulous chefs in it.